Okay, so first thing I want to say is welcome to each and every one of you. This being the very first manual therapy special interest group meeting here in Australia, and you are all here. The whole registration process crashed down because it got booked out within record time. Even today, people were ringing and contacting and saying, "Can I come?" I said, "No, it's sold out, we're overbooked, we can't fit in. Wait till it comes out on DVD." And so thank you for being here, thank you for making the effort, thank you for braving the elements out there, and really looking forward to this evening having the opportunity to contribute to your professional abilities and ways to actually help more people, because we're going to be focusing on this feisty condition of plantar heel pain, and got some tricks that we've certainly found just in recent times to be incredibly effective, and so I'm really looking forward to sharing those findings with you. There are probably a couple of questions I'd like to ask first of all. Who here uses exercises as part of their orthotic therapy for treating plantar heel pain conditions? Just a show of hands. Great, excellent. Who has ever experienced frustration with patients either not doing the exercises correctly or not even doing them at all? Who's had that? Yes, plenty of times here as well. So tonight is really about showing you and going through an exercise plan that helps alleviate those frustrations. And speaking of frustration, don't feel bad about interrupting me. No, I said don't feel bad about it. Okay, so you're going to have to give me the nod, because next time someone walks down here, we're going to have to do something really embarrassing for them. Okay. So a number of key objectives that we are going to be working on achieving tonight. The first one is I'm going to ensure that each and every one of you is able to cite the physiological and biomechanical theses of recalcitrant plantar heel pain. The other thing that you need to be aware of, or that I'm going to make sure you are aware of, are 3 physiological phases of soft tissue rehabilitation. And these are particularly important because there are 3 distinct phases that need to be treated 3 distinct ways, and they need to be done in a specific order. It can make a dramatic difference on the success or lack thereof in dealing with plantar heel pain cases. Then we are also going to know how to prescribe 5 essential exercises to enhance your results for plantar heel cases. These exercises you are going to be able to prescribe, but you're also going to have the opportunity to actually practice doing and being on the receiving end, as if you were a patient as well. So it's going to be more than just me talking, it's going to be a lot of interaction and actual doing from your point of view too. The exercises that we'll be going through are based on validated research evidence. Our colleague, most of you will know Simon Barthold from Barthold Biomechanics. He actually included one of these exercises, a new exercise, certainly new to us here at Foot and Leg as well. This particular exercise made his top 10 articles of 2014. How many of you have actually seen or read his summation of the top 10 articles for 2014? Show of hands. Great. So log on to Barthold Biomechanics and get it. It's if you're ever pressed for time and wondering what are the important articles that you should be reading, here's a great summation. So it really is worthwhile. Okay. I'm going to go through a number of references tonight, and I'm going to go through a number of key files and links that I'm going to refer to. You are all going to get a copy of those. I have a handout for you that's written. What I'll also do is email them to you, so the hyperlinks you can easily just click and get to them as well. So by all means take lots of notes, because note takers are a very good thing to be doing. But just know if there's anything that's been missed, or I promise to give you something, you will be getting it. If not tonight, in the next 24 hours. Okay, so let us roll forward. Here at the Foot and Leg Centre, North Adelaide, also in our centre in Glenelg, approximately 8 out of 10 of the new clients that we see have seen or tried some form of treatment for their plantar heel pain conditions. 67% of them already have some type of orthotic intervention or orthotic device that's been provided. And to bring a note, then come on in, find a seat, make yourself comfortable. I can't share the stage with you as well. Okay, so we've got a high percentage of the clients that we see who have already seen someone else or had some other type of treatment, but have still not got a satisfactory resolution of their problem. So looking for options, and we seem to, a lot of the people who come to see us, we often hear that, you're my last resort, I tried everything else. So we have, I guess, the opportunity to work with a lot of what we like to affectionately call our basket cases. So we're also very proud of the results that we've been able to achieve. And one of the things a wise mentor told me is that you don't find new answers by looking in the same paradigm. So I really want to acknowledge you all for being here tonight, being willing to put your foot inside a foot and leg centre and look at exploring some new options or new ways of potentially helping people. Tonight, I want to, glad Mike's here, because just in our last team meeting, Mike was talking about a client, Lorraine, who had had her 1 month review. She had been suffering chronic plantar heel pain for 18 months. She had seen 3 podiatrists, had 3 different pairs of orthotic devices. It reminded me a lot of when patients used to come and see me back in my early days and they'd say, look, I've got orthotics. I said, yeah, but you haven't had mine. And so I know none of you would be arrogant enough to think that yours was superior, but anyway, Lorraine had 3 lots and was essentially told that these ones will get the problem solved. She's also seen a physiotherapist. She'd also had manual therapy done in the form of fascial release, kinesia, taping. And so when she came to us, she had a bucket load of skepticism. So that was just the situation. It's not an uncommon situation that we get in our clinics. At 1 month for the follow-up review, she reported a 90% improvement in status, which she had not achieved anywhere close to that in 18 months. So what had happened was the exact exercise plan that we prescribed for Lorraine is exactly what I'm going to go through with you tonight. And the way it works, particularly in conjunction with orthotic therapy, is you'll find it'll actually enhance or improve your orthotic results as well. So that's what my goal is for you tonight. Before we launch into the content, I do need to make some clear distinctions about what is it that we're actually discussing, or what's the condition, the case that we're going to be referring to. So specifically, it's going to be either fascial or perifascial inflammatory condition that has come about due to some mechanical or biomechanical compensation. The key assumption that I'm going to be making here is that you will have made a differential diagnosis. You will have eliminated these conditions, whether there has been some nerve entrapment or systemic disease involvement, any seronegative, seropositive arthritides, rheumatoid arthritis. But one thing that is often in my awareness with rheumatoid arthritis, what is the most common site of rheumatoid arthritis? Where in the body? Do you know what the number 1 site is? Can I have a guess? Almost. Second. The knee. The knee is the number 1 site presentation. And that is the only site that's more common than in the foot. And so be really careful about where, I know I've been caught out with this as far as rheumatoid arthritis, plantar heel pain. Is it metabolic? Is it mechanical? Important distinction to happen there. Also Reiter syndrome, particularly in men who are under 40 years of age. So make sure that those differential diagnoses have been taken care of. for tonight's exercise, that they have been eliminated. They're not in the circumstances that we're going to be dealing with. We are going to be dealing with the physical tissue stress of those facial tissues. Any questions so far? Oh, okay. Yes. So, if I'm hearing you right, you're asking, how do you know it's what we did, or it wasn't just going to get better on their own anyway? I did a placement with Jim Ganley in Philadelphia back in the 80s, and his wise words still resonate with me today. Take it on in. And they were, if people get better while you're looking after them, claim it. So, I'm claiming it. And you're right. Would it have happened anyway as a result of other things? Yes. All I know is that this is what we can notice, or this is what we record in our situation. And yeah, it's a valid point that you raise. But I'm not going to...
Most of what we did, so anyway.
Yeah. It's just I can't agree with you because it doesn't support my position. So.
I'm not being the devil's advocate. I'm just saying, do you allow percentage of people to just resolve because of, like, that's what's going to happen?
So when you say allow, not intervene, not do anything for them?
Well, I mean, they're already having other conditions as well.
Yeah. No, the reason they're coming to us is, I've been doing all this, I'm not happy with where I'm at, have you got anything else? And invariably the way we assess and the way we treat them has not been done before. So from that perspective, I'm confident saying, we'll do this and see what happens.
Would you find, Ted, though, that if clients choose not to undertake care with us, then they come back a month, 2 months, 3 months later, and there's been no change?
Yes.
So for whatever reason, they like choose not to take care of it, it's not harm. So I know from being anecdotally that I can say lots of clients will choose not to take care of their money, and she'll be back and say, it's still not better, I'm ready to go now. So that's a little bit of control.
Yes. Yep. Yeah. Any other questions? All right. So now we get into the field that really is our area of expertise as far as providing healthcare services in the field of biomechanics. There is a universal law that I don't reckon is written or published anywhere, but Rob can correct me if I'm wrong. But mainly because I don't think it's published anywhere because I think I made it up. And what that law is everything works best when... Who here has heard me lecture about this topic before? Show of hands. Yes. I was going to say, weren't you listening? Great. So those of you who have heard this before, I'm just going to ask you to keep your mouth shut and let anyone else. Think of this as a universal law, not specifically related to biomechanics or function of the body, but it does apply equally well there. When does everything work best? Okay, so now what we're going to do is a particular skill that, particularly in high school, I excelled at. It was a thing called cooperative learning. And what cooperative learning is you're going to turn to the person next to you and say, geez, I don't know, what do you think this is? And exchange ideas. If there's 3 of you, you can all 3 join in. Problem is that in high school it was called cheating. But we're going to use it in the real world. It's cooperative learning, because if you don't know an answer, then see if you can find someone who does know the answer. So spend a minute, just turn to the person next to you, introduce yourself if you haven't already met before, and find out, what do you think is, when does everything work best? Thanking you and newfound buddies. What did you come up with? What do you think? When does everything work best? Everything works best when? Okay, next thing we're going to do is, when I ask a question, your job is to answer. That's it, right, okay. So, there was a lot of talking going on here. Surely you picked up some ideas. Everything works best when? What did you come up with? What did you think was? Katie?
When everything's in the right place.
Oh, beautiful. Thank you, Vinny. So brave. Okay, exactly. Everything works best when it's in the right place. Whether it's, I'm thinking straight away, my desk at home, my filing drawer at home. Yes, if everything's in the right place, everything works best when it's in the right place. If we think of foot function, foot mechanics, the complexity of the joints, the articular surfaces, the insertion of muscles, ligaments and tendons, you know, it all works best when it's in the right place. Is that published anywhere, Rolf, do you think? No. Maybe. Certainly the concept would be. Does that make sense? Okay. It's a simple idea, but the fundamental premise to what we're going to be doing tonight. Now I just need to double check, just to put this in some practical context of what we deal with on a day-by-day basis. Who here has heard me speak about the beam principle before? Just a show of hands. Okay, great. So it's the same deal. I'm just going to ask you to keep a lid on things and let the others explore this phenomenon. Okay, so there was at one time, it might still be called the columnar theory of foot function. It's not an accurate term because in engineering terms, beams are horizontal, columns are vertical. So I use the term the beam principle of foot function. And good. Okay. So those of you who are standing, there's an observation that some of us can see that your feet look like this. And it's obvious. It's the pink toenail polish, isn't it? So what is it about these feet? Oh, it's not... I apologise, the image is a bit compressed here and it's distorting the clinical findings. But what is the clinical finding? What's the clinical observation here that would suggest there might be a discrepancy between the medial beam and the lateral beam of the foot? Any guesses? The bunion, okay. Medial, yeah, no, that's not the clinical side. Anyone else? Anyone else want to hazard a guess why there might be a discrepancy here?
Metatarsal parabola.
The metatarsal parabola. How would we see that from this view? What would we see? Because can you see the metatarsal parabola here? Not particularly. However, there's something else you can see.
Digits.
Yes, the digits. What do you see with the toes?
Second and third. The second.
Yeah, a little more obvious on the left. What we're seeing is the first, second and third toes, the parabola, the natural toe parabola, and the fourth and fifth are more proximal compared to a distal displacement of first, second and third. Can everyone see that? Okay, it's just a clinical observation, it's not a diagnostic test here. However, those of you who are standing, please have a seat. Oh no, stay standing. Have a look at your own feet and tell me, can you see? So I'm looking at Rolf's here, it's 1, 2, 3, and then straight away 4, 5 happening on both feet. Yeah, okay, so probably more right foot. Oh, it's on both feet, yeah, good. Ooh, it's contagious.
What if the first four are the same?
Yeah, I know, that's why you were kind of, I was looking more on your right foot, thinking, oh, maybe. Great, have a seat everyone, and so what it was an observation I made some years ago, that if we think of the foot as in two beams, if we get on the medial beam a shift of the talus, shifting anterior or displacing it antero or anteromedially, you get this domino effect into the navicular, into the cuneiforms, into the first, second and third. Just kind of everything cascades forward. And you get a shift of the medial beam relative to the lateral beam. As a clinical observation, then what we often see is the first, second and third drops back to as far as the toe parabola goes. Does that make sense? Okay, could it be that there's just an anatomical variation in the length of the metatarsals or the toes? I mean, that's possible, sure. But as a first point of as a clinical indicator, it's like, if this is the case, the way to confirm it is actually through a weight-bearing X-ray and looking at the cyma line. And you can then tell the articular surfaces or the articulation between the talus and navicular and the calcaneus and cuboid. And if there's an actual shift of the beams, there's a break in the cyma line. That's not what we're going to go through in detail tonight. What I want to put to you is that if there is a shift of the talus, and when we see the excessive pronation of the subtalar joint, What does the talus end up doing? Well, it tends to shift anterior or anteromedially. And if you're getting that force with the talus shifting in that direction, this domino effect down the medial beam can lead to a discrepancy between the medial beam and lateral beam. Make sense so far? Okay. Any questions about that? Okay. So, the key thing here to be mindful of is, how many of you think that the talus could actually shift from its optimum position? Who thinks that's possible? Okay. Who thinks that's not possible? Who doesn't know? Who doesn't care? All right. The talus. What a beautiful thing the talus is. From a biomechanical model perspective, if we look here, we've got the lateral beam and the medial beam, and we're looking at the shift. If we get a shift of the medial beam relative to the lateral beam, now I've just highlighted here the key attachment points of which band of the plantar fascia is the one that typically gets aggravated or symptomatic. We're told medial. Latest evidence now is suggesting it might be the middle band. I think it's, I forgot, is it 7 or 17% of cadaver experiments showed that there wasn't actually a medial band present. But I digress. So even if it's the middle band, you get a shift of the medial beam relative to the lateral beam. What's that going to do to the tissue tension of the medial or the middle band of the plantar fascia? Increase or decrease?
Increase.
Increase, it has to. So then we get to the point of, well, you can do any treatment you like as far as, reduce the inflammation, you can stretch the tissues, you can inject cortisone. If this is the cause, this mechanical discrepancy between these two beams, if that's the underlying cause, it doesn't matter what anti-inflammatory or treatment methodology you use. If this is not addressed, what's your success going to be? Higher or lower? Or is this going to be a reason why these conditions can be so recalcitrant? That's the theory I'm going to ask you just to consider for this evening. And tomorrow, when you get your client coming in with heel pain that hasn't resolved for 12 or 18 months, it's something that's worth bearing in mind. Now, I'm working on the supposition here, or the proposition, that the talus shifts or displaces. Now, the fact is, it does. Recent study that was conducted in it was the Accident and Emergency Department, and did a summary of, I forget the number, hundreds of ankle injuries. In 92% of ankle injuries, which is the first structure, the first ligamentous structure that gets compromised, damaged, stressed, or affected? ATFL, yes it is. Here's the beast here. What is the number one function of the ATFL? To prevent anterior displacement of the talus. Holy moly, look at the shape of it. See, the talus good, get rid of that ligament, the talus is just, that's the thing, that's the primary ligament that's anchoring the talus into the ankle mortise. It gets injured 92% of ankle injuries. If we were to, I'm looking at you because you've got the extreme flatty footwear here, but we went from flatty footwear and we put you into a heel, what does that do to the talus? If you were dancing, partying all night long, because I know you got that lined up after you leave here tonight, what would be the direction of force on the talus if the foot is in a plantar flex position? Yeah, it's a tendency to go anteriorly. They had a really interesting example. A client who was a yoga instructor and had this plantar heel pain case that I couldn't work out what was going on. She was doing everything that we asked of her and just couldn't piece together. So I literally made her keep a diary of every activity she did right through the course of the week. And as a yoga instructor, she would spend up to 10 or 15 minutes in this position per class that she was teaching. What is this doing to the talus? Putting it down here and then put the body weight on top of it. It's like shelling a pea. You're pushing the talus out front. What is that going to do to the anterior ligaments, capsules, and the ATFL? It's going to literally put them under strain here. This, and as soon as, if you take nothing else from tonight, if you have people, your clients who are doing yoga and have a condition related to displacement of the talus, like plantar heel pain, stop them doing this. They can be in this position, just have their toes tucked forward. And typically they'll stay there for about 15 or 20 seconds and then it cures. But it's really good for hammer toes and claw toes because you stretch all those tissues out. You've got to get them either, you've got to get the weight off here. Sit on a meditation stool so that literally the foot in that position is not such a bad thing. It's the body weight on top of it. That's the key. But then have another cracker where we're getting this run of mums who are coming in and recently had their baby with this plantar heel pain cases going on, thinking, what is happening here? Well, obviously it's the hormonal changes, it's the ligamentous laxity, it's all these things. But then I noticed how many mums sit on the floor with their baby, changing the nappy, or just being with their child. Like, would that be not an uncommon position for you? Yes. I'm thinking, holy moly, you're sitting on your talus in this position here. I'm not saying that this is causing the displacement, but it's a factor that may be hindering or preventing you from getting the resolution of the problem because of that anterior push in the talus. Make sense? A couple of take-home clues there, or yes, if you have just some key questions to ask about their activities and whether they're on their feet. Some people ask, well, what about sleeping? You know, if I sleep on my stomach, so my feet are in this position. I'm not convinced that it's a major fact, other than you're in that position potentially for many hours, but there's no body weight on top, unless, you know, there's winter and there's quilts and things. And I have very little sympathy for people who sleep in that position, because I sleep on my stomach a lot, but my feet hang over the end of the bed, so I don't get this position. Simply, maybe Rolf and I are on today. Okay. Okay. Any questions as far as biomechanics premises that I've got so far? No? Okay. So now let's launch into... Oh, did you have a question? Sorry.
When you're talking displacement, what's the amount of displacement?
Displacement. So the Dorland's Medical Dictionary defines subluxation as a loss of relationship of articular surfaces as demonstrated on X-ray. So if you've got two bony surfaces that should be lined up in a certain position, and if there's a shift or a displacement, that means there's dislocation or luxation. Subluxation means partial or less than a dislocation. There are degrees of. And that goes from 1% to 99%. That is, how much is too much? I have no idea.
But you're talking that you're saying your medial being is lengthened.
Yes.
So for that to be beyond physiological parameters that the plantar can handle, if we're talking, you're saying that if there's a 1 millimetre displacement forward, that's going to overload the plantar.
I've seen it where there's not been a displacement, but it's the tension, the beams are not displaced that we can see. But there is, because one of the other clinical signs is if you palpate the anterior ligaments, medial and lateral, and the number of times that you get a trigger point forming in there because of that tension that is being placed on those is, I suppose, another clinical observation. I don't think you can say there's going to be a certain number of millimetres of displacement, because what if that happened over decades? You know, if that was what's happening with you, this is almost a lifetime thing that's occurred, and then how do tissues adapt and modify? Yeah, they'll probably remodel and modify themselves around there. If it's something that happens over time, the body's got the opportunity to adapt to that. If it happened more acutely with the beginning of football training, as we're seeing now with pre-season training for a footy, getting more of this type of condition occurring. So I don't think we can quantify that it's got to be a certain number of millimetres. I think it's something that's worth bearing in mind when you're assessing a patient to see whether this could be something, a possible biomechanical compensation patterns going on. So I didn't answer that anything, did I? I don't think there is an answer. It's certainly not in a mechanistic perspective. Yeah, Mike.
Does it equally apply to the caver's foot?
Yeah, yes, it does, except the talus tends to shift in a lateral direction rather than anteromedial. Often what happens is the talus can still shift in an anterior direction, but often lateral. And then you get the whole, almost like torsion effect through the midfoot. So, probably don't see it as clearly or as readily visible between the beams as you do in a pronated pattern. Yeah, times.
Mine just, observation in using orthotics on clients to try and help with this problem is that medial beam tends to come in, reduce a bit anyway because of the effect of the arch being raised, and in effect would that bring the talus back in a bit or take the tension off?
To what degree does an orthotic device influence the position of the talus, is my question to you.
Yeah, well, as I said, it's my observation.
Yeah, I don't think it has an effect on the talus. Does it have an effect on the other musculoskeletal structures? Quite likely. I'm assuming that would be highly likely, but not specifically of the talus.
So the orthotic, the lifting of the arm, say the pronated foot, if
Yes.
the medial beam is lengthened, you don't believe that shortens that beam at all?
No. I think it affects the tissue tension through the foot, but the actual position of the talus, haven't seen it shift or change. Mike, have you got anything else that you'd like to add, or any observations? Orthotic intervention on the talus?
Visually, of course, if you lift up the arch, you are potentially shortening the disc between toes and heel, visually. But in terms of tailor influence, agree, it's very difficult to actually shift talus with an orthotic device.
Yeah, there is no
The
direct
forces don't push
on the talus.
So if you're physical twin vectors, you're not applying a counter force to drive it posteriorly through an orthotic device.
Yeah, that would be, yes, that would be my observation as well. Okay, physiology. Now, question I have for you, what is true healing? How do you know when something is actually truly healed? How do you define true healing? Remember that I asked the question, which I just answered?
Histological evidence would be true.
Yes, histological evidence. I've never had anyone say that before. What kind of histological evidence are you referring to?
Symptoms.
Yeah, so certainly symptoms from a clinical perspective. I want to get down to the histological part.
Well, not that you would ever do it, but like actually looking at the fibres and seeing what's going on.
Yes, and what would you expect when a damaged or stressed tissues were healed and repaired? What would have happened? Oh, I love your thinking.
I've got a baby brain that's done.
So those of us who haven't had babies in the last few weeks, what do you think? True healing? Because you're right on the track here. What would true healing be? Histologically, what takes place?
Rearrange.
Yes, rearrangement, I like it. Of?
Collagen.
Yeah, literally, I'm talking about the healing of any tissues. Let me put you out of your own. Think of this. True healing is when the old damaged cells are replaced with new healthy cells.
In the right place.
In the right place. Because everything works best when it's in the right place. But true healing, I like the definition, that true healing is when old damaged cells are replaced with new healthy cells. From a symptomatic perspective, you can actually feel better, but not actually have those old damaged cells replaced or turned over yet. The thing to appreciate is in our bodies, in everyone's bodies, our cells are turning over all the time. We get a new stomach lining every 7 days. Skeletal muscle turns over, the cells turn over every 12 to 14 days. Think of the last time, I'm going to say, have you got a brother or a sister? little sister, kid sister, when she punches you in the arm, you get a bruise. Like, how long does it take for a bruise to repair itself? You probably think about 12 to 14 days. You get a decent bruise, then it's sore and then it starts fading and goes a bit yellow, but it's only about 12 to 14 days for those old damaged cells to be replaced. Collagenous tissues, ligaments, capsules, how long do they take to turn over? Any idea? 6 months? Nah, it's actually osseous tissue. It takes 6 months. And skeleton cells, osseous cells turn over. But collagenous tissues, so the tendons, ligaments, capsules, they take around 6 weeks. Now think of a decent ankle inversion sprain. Like, how long does that take to truly heal? Well, you get a lot of swelling, you get sometimes bleeding, you get the inflammation calms down, it's sore 2 or 3 weeks, you can kind of get back into activity. But actually, for all those damaged cells, it will take around 6 weeks. A decent ankle sprain takes about 6 weeks to fully repair. This is quantified in a number of studies that were done in Scandinavia, where they're happy to inject all the neutron bombs into cells to see how long it takes for them to turn over. That Scott Waring in Queensland put me onto a number of papers. This one just shows collagen activity, what it does. It takes around 6 weeks to turn over. And that's why a decent ligamentous sprain will take about 6 weeks to fully heal. You can certainly feel a lot better well before then, you can still use it, but to get true healing of that tissue will be about 6 weeks. Make sense? Okay. So that means when we're dealing with a condition like fascial or perifascial inflammation, true healing of those tissues is when the old damaged cells are replaced with new healthy cells. And because they're collagenous tissues, how long are they going to take to turn over?
6 weeks.
6 weeks, exactly. So the exercise plan that we're going to go through is actually a plan over a 6-week period of time to work with Mother Nature, to work with the way the body turns the cells over and you get true healing. Not just symptomatic relief, it's about getting true healing, which is the old damaged cells histologically replaced with new healthy cells. So that's the plan. Now, there are 3 phases that tissue rehabilitation needs to go through. They are stretch, strengthen, and stabilize. And it's got to be in this order. So any damaged tissues that you're going to rehabilitate, you've got to go through a stretch process first. Then you begin the strengthening, and then the stabilization. So this is based on a number of references that Mtxsig refers to in his excellent textbook, Foot Orthosis and Other Forms of Conservative Foot Care. So it's these 3 phases that we're going to go through with the exercise plan to make sure that we do the best in the right order from a physiological perspective. Before we launch into that, are there any questions about anything I've covered so far? Or any other questions? No? All right. Who here has or has had a history of plantar heel pain in recent living memory? Anyone? Katie, seriously? You should see a podiatrist. Good. You might be a suitable victim for me. Okay. This exercise plan. The plan I'm going to show you, the way we map it out, the way you instruct and teach and get your clients to do this, has a... Oh, let me ask this question first. What is the #1 complaint physiotherapists have about prescribing exercises to their patients? Compliance, yes. So I'm very pleased to say that this plan that I'm going to show you, in our experience, has a greater than 90% compliance rate, which is really good. Now, the way we record that, I'll go through in just a moment, but we combine it with our foot health status questionnaire as far as its symptomatic rate recording too. But we get better than 90% compliance rate, combines very well with orthotic therapy, and it follows this specific 3-phase plan here. So, this is what the plan looks like. Now that we get into the practical stuff. If you take a typical orthotic treatment plan pathway, the details here will be moving a little bit, but essentially what will happen is when you see a client for the first time, I'm working on the assumption that you'll do an assessment, a biomechanical evaluation, determine that orthotic therapy is going to be a valuable, worthwhile intervention, and then you will either cast or do a scan or some type of impression for a negative mold. And that will typically happen in week 1. Then in week 2, or 2 to 3 weeks later, you will dispense the orthotic devices, and then you'll do a follow-up, whether that's going to be about week 4, 5 or 6, thereabouts. And I'm speaking with a lot of podiatrists over the years, a follow-up in about 3 months is also not uncommon. So this is the orthotic path. If you do something different or vary it, what I'm going to suggest you do is just take note of what happens at this time frame. The way we work here at Foot and Leg Centre is we will work with our clients in literally 6-week cycles. And the first 6 weeks is a lot about creating structural change, and then the second 6 weeks is about consolidating those change for the long-term benefit. We work in 6 weeks. Why? Why would we work in a 6-week cycle? Because that's what Mother Nature does. She turns over those collagenous cells in 6-week cycles. So we work with Mother Nature. Here are the exercises. They're going to consist of a gentle tennis ball massage. Then we're going to do the Jedynak stretch. Then we're going to apply a calf stretch. Then we're going to do some deep tissue dowel massaging, which is another stretching activity. Then we're going to do the Rathliff strengthening, which is what I referred to in the beginning about, it's a strengthening exercise that was in the top 10 articles from last year. Then we do proprioception. So we start off proprioception level 1, and then proprioception level 2 and 3 are basically just more challenging proprioceptive activities. Why would we be doing proprioception at the end? What would be our objective? What are we trying to achieve here? Stabilize. So it's about getting better neuromotor control and stabilizing joints, because everything works best when it's in the right place, and we want to keep things in the right place and help the body help itself keep things in the most effective position. So what I'm going to do right now is give you some of Ted's tips, and these are the must-dos of exercises. First one is kiss and kiss. Any guesses? Why 2 kisses? Because I'm European, we do both cheeks. No, that was just a joke. Keep it simple and keep it safe. So keep it simple, keep it safe. That's what we want to do. Make sure, particularly when we start getting some balancing activities, make sure your clients are safe. Ted's tip number 2, provide clear, easy written instructions. Different people learn in different ways, so we'll give them the instructions verbally, but also giving something in writing is very useful. Demonstrate the exercise so they can see what you're doing, and then get them to do the exercise as well. So when you combine keeping it simple, keeping it safe, clear instructions, demonstrate the exercise and do it, goes a long way to improving the compliance rate. Because I don't know about you, but in the early days when I used to do exercises and say, great, okay, now show me how you're doing the exercise. And they'd be doing this creative thing. So where did you learn that? It's exactly what you told me. So no, it's nothing like I taught. So, our patients, our clients can sometimes interpret our instructions in different ways. This just stacks the, the laws of probability in closer to getting the optimum result. It's not a 100% guarantee, but these are certainly very useful points to include these. It increases your chance of good success and good results. So, who is going to be my volunteer for the exercises? Oh, okay.
KO.
Oh, God.
He's probably Ted. It's all right.
Good.
He's going to fix you, Kev. You'll be right.
I've been fixed already.
Oh, mate, not like this. Not by me, though. Great.
He'll claim it.
You bet I will. Tennis ball, just inside that box. No, sorry, that's the rubbish. Yes. Tucked in underneath. Okay, a little bit of health and safety coming my way. Oh! I wanted to do that. Okay. Great. Kevin, have a seat. Yes, please. All right. Now, what I'm going to do, I'll demonstrate for you for purposes of demonstration. You will see on the back wall there that there's a whole list of our exercise handouts. So the first one with the tennis ball, we've got literally all of our exercises. Okay. The handouts themselves are based in the what, why, how. So this is what you're going to do, this is why it's beneficial, and this is how it's actually going to work. So Kevin, the way this exercise is going to work is, first of all, sitting down, you're going to just rest your foot on top of the ball, just the weight of the leg, you don't push your foot into it, and you're going to gently roll the ball over, your foot over the ball, the length of the foot, for 20 seconds, and then you go in circles, through the ball of the foot, through the arch of the foot, through the heel of the foot. Cool. If I get you to try that for me, it's actually going to be really difficult on the tiles because it's going to slide everywhere. So you just go the length of the foot, beautiful, great. So this is a really, particularly for plantar heel pain cases, it's a really nice, gentle way to go. The instructions we will be giving with this is best time to do this is first thing in the morning, last thing at night. Yeah. So have the ball by your bedside, sit on the side of the bed, and then get to work before you put your feet to the floor, because we know first steps are the most painful, typically, and you get to work. So I would then go through that exercise with you. Beautiful. Then the second exercise, this is the Jedynak stretch. How many of you here are familiar with this specific stretch? Okay, great. Who's not? Okay, terrific. This is a fantastic, for symptomatic relief, it's a way to really be able to isolate the medial portion of the plantar fascia. So literally the way this works, what I get you to do, Kevin, is put your heel over like so. Now, with your left hand, you're going to place your thumb right over this point. So you want to isolate the origin, and typically it's where the plantar fascia hurts, where it inserts into the calcaneus, and then literally by dorsiflexing the big toe, pull and hold as tight as you can. You see the bowstringing effect, right, so here. Terrific. You hold that stretch for 30 seconds. Okay. This particular stretch, you basically can't overdo. So if you're sitting at the office anytime, even, with shoes on it's a little difficult, but if you've got the socks on, then you can bend over there, stretch, hold for 30 seconds, and the reported symptomatic relief with this one, just to get relief, it's technically, I don't think you're stretching the plantar fascia as such, but those inflammatory tissues and those tight tissues around there, you can exert some good influence here. So you can almost instruct your clients, you can't overdo this one. So it's 30-second holds, that's important to get that hold in place for 30 seconds. And typically, the position here is quite manageable.
How much force is being applied by that right thumb?
It's firm, it's kind of just holding it in there as a guesstimate, 7 or 8 kilos. So it's quite firm, but you're not digging in. It's not like a trigger point treatment that you're applying. It's really just to anchor it, and also so that you can apply. You're isolating the force on that medial band. That's the objective after here. Okay. Then. A lot of our clients live in houses where the walls are really too close, so we just get them to push all the walls back out to give them more room for... No, I was only kidding. This is a calf stretch. No, generic calf stretch, however you do your calf stretch is absolutely fine. Is there anyone here who doesn't have a way of doing a calf stretch that they prescribe? No? Okay, so we should all have this. Typically, the one we most commonly use is a small step like so, standing on the step and then just letting the heels reach out. But not everyone's got steps. We used to say, we'll just stand on the yellow pages, But then the modern generation, everyone's standing on their iPads and saying, well, that's not working. So, okay. So calf stretch, whatever you choose there, and I'm sure, Kevin, you have a calf stretch that you've prescribed from time to time. Then the dowel. Now we can make things work for you. Okay. Everyone's hiding. Rob, would you mind reaching under that tablecloth? Keep coming. The next one, keep going a little bit further.
Yep.
Don't throw this one. Yeah. All right. Also affectionately known as the Teddy Torturer. Piece of dowel. We pick these up at the local Bunnings and get big meters of it and chop it up. Because one of the other things, it's another Ted's tip that deserves to be here. If you have any bits that you're going to expect your clients to use, provide it for them. Because if I have to wait for you to find a tennis ball and all that, it's just another obstacle. So we provide all of our dowels. We used to use 22mm diameter. I got sick of them being thrown at me though. So we now use 19mm. And it seems much more workable. It's you're going to find out, it's a very special experience, but it has a very specific, useful stretching effect of the tissues through the soles of the foot. We will do this on the carpet. Oh, the tennis ball. Great. So the way it works, Kevin, is the dowel itself doesn't move. What you're going to do is you're going to stand on the dowel of the ball of the foot, and then you're going to slowly work your feet over. You'll see how I'm using my toes to drag the feet. So I'm just lifting the heel and dragging the foot forward. So each step is about 1 centimetre. Visual cues back for those of you who can't see. And slow. When you find a special point, stop there, hold for 5 seconds, and then carry forward. Find another one, stop, hold, and then go forward. You'll get all the way through to the heel, and then you go, maybe 3 more times. Back to the ball of the foot, and then away you go again. So great, just try that for me. Sometimes it's easy to do with socks on because you can slide over more effectively. And if you can use your toes to kind of grip, it's this concentric.
Yeah, the big size. Your arms are stopping me from doing that.
Oh, okay, great. Well, not great, but that's really useful feedback. So he's complaining about neuromas here. Imagine if you've got someone with really tender plantar heel pain and you try to get them to do this, you're going to cause a lot of distress in the early stages. So if it's too, and as you'll see in the plan, this doesn't happen until week 3, week 4 when they've been doing a lot of other things already. But if you step off for me, then, so I was actually prescribing this, I said, okay, look, if that's too painful, too much, we're going to get you to do it sitting down, just leaving your hands on your knees, and then kind of crawl over that way. So you just modify the amount of force going through. This has been transforming in getting specific, and as you can feel, it's like it gets in. It's like your own personal Swedish massage in a very special way. So that's the dowel exercise. So yes, this is the handout that we use. So you see why do this exercise? So it's to help free up the restrictions through the soles of the feet, and then how to do it. And then there's a place for you to write in how many repetitions, how often during the day, and special note, the dowel does not move. So sometimes, because one of the things people do, they go rolling backwards and forwards. That's not the exercise, but there we are.
Excuse me. So what do you mean by a special point? If you found a special point there, you stay for 5 seconds?
So it's a tender point or a trigger point. So it's the quality of sensation, and as they're going on, you see their face, you watch it. And as soon as at that point, stop there. For some people, it's too painful. So usually the ways we'll grade it is you get a couple of chairs, take some of the weight in your arms, so you can control how much force is going through the foot. If that's still too much, then go to sitting down. So you adapt it for their abilities, their needs.
So is that like a stretch, or is that an ischemic compression type thing, or?
The specific stop and hold.
well, how the dow's working, like what you're trying to achieve.
Yeah, so it's literally it's just tearing apart the micro tissues that are locked in together.
Yeah.
So it often causes some heat and inflammation and reaction with that. You have to gauge what is therapeutic and what is masochistic. So work that out. Okay. So this is the article that I was referring to, and this is Barthold's summary here. So the article was this titled "A New Method for Treating Plantar Fasciitis," and so this is the handout, and again I'll show you where you can download this particular file from. But if you look at the images, what this is it's a strengthening exercise. But it's the way the strengthening is done that's most important. From a historical perspective, we used to incorporate toe scrunches and heel raises. This has an effect of eccentric strengthening, and it is, yes, the evidence is now showing that this is the most effective way to get assistance and relief with the plantar fasciitis. So there's key stages here, and this is, I'm not going to be able to demonstrate this because normally we do it on that small step there, but I'll talk you through it. In fact, Kevin, if you stand behind the chair, and let me just, I'm going to hang on to the back of the chair here just as we would be going here. So the first repetition, so I'm going to describe to you one repetition. You're going to end up doing 12 repetitions here, but the way the repetition goes, and where I was instructing you, you'd be positioning. So first of all, there's going to be on a step, and the toes need to be dorsiflexed. So you're literally going to get a lot of that tissue tension through the sole of the foot. It's going to be taken up by the toes being dorsiflexed. All right. So once you're in that position, you're now going to do a heel lift, but you're going to take 3 seconds to get up to that full heel lift position. When you get to that full position, okay, so going up, 3, 2, 1, you will pause for 2 seconds, and then you slowly lower yourself down so that the heel goes lower than the ground level, and that takes 3 seconds. What this study highlights is the speed that you do this exercise. It has to be very well controlled. So I was balancing here, but you've got to be hanging on, so it can be very well controlled. If it's done too quickly, it has an aggravating, irritating effect. It's more of a damaging effect rather than a beneficial effect. So the key here is the timing. So take 3 seconds to go up, pause for 2 seconds, you go all the way down for 3 seconds, then you go back up for 3 seconds, and take 3 seconds to do that, and that's one repetition. So this one here, you literally have to put facilities and time aside to do this exercise. But when you've got a plantar heel pain chronic condition, and you've tried everything else, people are willing to do this. This is a really, really useful exercise, and it's a new one to certainly our library of exercises that we found very useful. Great. Then, and proprioception. So proprioception, great. Just have a stand here for me, please, Evan. I'm just going to get you to rest one hand on the table. Great. So first, the way this exercise works is I'm going to get you to lift one leg into the air. I didn't say Simon Says. Okay, lift one leg in the air. I didn't say Simon Says. Got you again.
Okay, let's go.
Simon Says. One leg into the air.
Yes.
Right. Once you're in that position there, great. Your weight-bearing leg, just bend the knee slightly.
Yeah.
Great. Then what you're going to do is let go. Oh, sorry, before you do that, with your foot, just artificially, slightly lift the arch of the foot up.
Yeah.
So what we're going to do is just slightly supinate it, almost like 1 plus. Great, and now let go. Then when you let go, you'll be wobbling, wiggling.
Absolutely.
Okay, that's the exercise.
Yeah.
This is your brain now talking to the muscles, how do I keep me in this position here? What's important, make sure you're safe. Often, both feet on the floor. Okay, so we'll often recommend that our clients do this in a doorway. So when they're standing there, so if they lose their balance, you can just sort of grab hold one way on the other side, one side or the other. So literally level 1, if we've got a gymnast and they go, well, that's no trouble, then you make it more challenging. So level 2 is our egg beater. So with the non-weight bearing leg, we'll get them to do big, slow circles. So the instructions, normally you'd hold for 20 seconds on one side, 20 seconds on the other side. It's the repetitions. Then egg beater, what did I get Kevin to do with his weight bearing leg? Say again? Bend his knee. Why? Yes, and what does that engage? Yeah, literally all the muscles. If you keep the knee locked, then what happens, you end up hanging off the ligaments. Yeah. It's not challenging, and it doesn't provide the proprioceptive stimulation to get the muscles firing and talking to each other. The real important point is make sure the knee's bent. So all the proprioception exercises are done with the knee bent. So level 2 is egg beater. So you do 6 big slow circles one way and then 6 the other way. Or you can get them looking up in one corner and then moving their eyes from one side to the other. That throws off our visual cues. Level 3, we'll get them into that position and then do 6 gentle squats. So again, controlled form, looking at making sure the knee is staying in a well-aligned or slightly, typically the pronated foot pattern will just slightly get you into a supinated attitude to get maximum benefit there. And level 3, level 4 is aeroplane. So normally they're cleaning their teeth at this stage, so you can rinse out one side. And then it just comes up to your imagination as to how much more challenging. You can do eyes closed, that's pretty challenging. I'm always hesitant to do that. The 2 most common times and places that our clients do their exercises are when? Any guesses? Sorry?
Watching TV.
Watching TV? No, haven't had that one. Literally cleaning their teeth or in the shower. Now, so you're doing this balancing in the shower and there's soap and stuff. I'm thinking, really? I don't recommend it, but that's the feedback we get. It's like, well, I'm not doing anything else at the time, usually, so it's a convenient time. This is the key. You can incorporate the exercises into an activity that's already a regular routine, link them in, then that increases compliance again. So it's like cleaning your teeth. We can get them all to do their cleaning the teeth activities that way. Having a dowel in the shower might be a bit of a trick, but normally these are kept by the bedside. Ted's tip number 15. With the tennis ball, if you're giving that, tell them to put it inside a stocking, an old stocking, and then hold on to it, because the number of times they're sitting there early morning and then and the ball squirts out and rolls under the bed, no. But if it's in a stocking, you just kind of pull it back and then away you go again. But actually, that was a tip from one of our clients, and very useful tip. And watch out for dogs, cats, and little kids who want to pinch the ball. Or people attending a CPD session who want to pinch the ball. Okay. Any other questions about those exercises? Yeah.
With the heel raises, was it a towel that doors flip into?
Yes. Yeah. It's a roll up a towel. It's that's it's probably a hand towel, tightly rolled up, so that it ends up being probably that diameter, just so that the toes are, pretty much maximally dorsiflexed. That's what you're after. Okay.
Just going back to the Jedynak stretch.
Yes.
You're saying that you don't feel that you can do it too much. What we're talking about is mainly those little micro tears and things in the fascia. So can you almost sort of have too much stretch on it at the start? You know what I mean? So maybe you go to a point where you can feel it a little bit sore rather than just going hell for leather where you're creating micro tears.
Okay, sorry, thank you for that. I didn't make myself clear. You can't do it too often, as distinct from doing it too much, because you could certainly apply too much force. And typically people are really enthusiastic to do it lots. I would say every hour. don't do it more than that, because if you're going to do it 60,000 repetitions in a day, that's probably going to end up being traumatic rather than therapeutic. Good. Okay, so here's the plan. Now, with those 6 exercises, you're going to have to remember what they are and what order they're in. I'm going to get you to pair up and spread yourselves out in the building. Alright, we all returned? Okay. So how was that? Did anything come up as far as the exercises, questions, things you're not sure about? There were some good questions while we were going around there. Anything else? Anyone else had some questions or anything that we've covered you'd like to raise?
Question was just raised about bilateral, like treating the foot that's not symptomatic as well.
Yes. Okay. Would you? Is that what you're asking?
Yeah.
Okay.
Or do you? Yeah. Should you?
Okay, so 2 things here. Distinction on the strengthening exercise. So I know they've also done a demonstration with single leg raise, and I think the idea is once you start doing 2 legs, and depending on the individual, within a week, 2 weeks, it's not really having as much resistance or not having as much therapeutic benefit. So then they go into doing it in single leg. So that's one distinction here. From your question, perspective, if they've only, I suppose, a fair portion of our clients will have pain just on one side. Would we treat both feet? Is that your question?
Yeah, like do the proprioceptive exercises for both legs and
Yes.
so on.
Okay. What do you think? If you've got someone with plantar heel pain, what would you do? Would you treat one foot, both feet? If they've got plantar heel pain, would you prescribe orthoses for both feet? Really? Why?
Keeping things balanced.
Yeah, the symmetry, and maybe I dare say the prescription would be different from one side to the other. But essentially that sense of harmony. One of the things we also do is, from an exercise perspective, is gait retraining. So yes, there's proprioception, but we also have what we affectionately call a John Wayne walk. So it's a supinated stance, and then people and they always do this with their hands. So it's a bit difficult to get them to do that on 1 foot only. So short answer, yes, yeah, we do. We just work on it symmetrically, and because in our experience, you can get a lot of connective tissue restrictions or joint limitations on both feet, but 1 foot may only be symptomatic. So getting that uniformity is what we prefer to do, and we customarily do. Yeah. Great. Yes.
The dowel, do you think that would still be as effective if you wrapped it up in something or made it slightly more comfortable?
So where we tend to focus on making it more manageable in the early stages, because invariably we get a lot of complaints that are serious. So the cues I mentioned to Kevin about wearing socks, so wearing thick socks is a good thing. Doing it on carpet versus a hard surface also means it can sink down a little bit. You kind of need to adapt and adjust for your specific patient's needs, because every person is different, and adapt where necessary. And who do you think are the ones that complain the most about that exercise? Men or women?
Men.
Oh, the men, they're all babies. I'm one of them. Yes, great. Any other questions? Okay. Who here has found that they've learned something tonight that they didn't know when they walked in? Show of hands? Great. So what I'd like you to do is just turn to the person next to you and find out what they learned and see maybe, that's 2 things I'm going to learn. So just take a couple of minutes and Speak to the person. Nice work. Thanks, I have a hard time shutting you all up. Alright. So, what did you learn? What did you find useful? What made your evening worthwhile? Your opportunity. Oh, now you're silent.
Jokes, man, your jokes.
Yeah. Speak to you later. Kate, what did you pick up?
I was saying that I've heard your B theory before, but I've never sort of thought about the fact that the plantar fascia starts in one and goes across to the other. And I think that I thought a lot about longitudinal, but not that medium to lateral sort of shift of the plantar fascia.
Yeah. Great. And it's just my goal today is just to help shed another light or another perspective. And if that means that you get to help one more person, then I'm going to be real happy, real thrilled about that. So yeah, great, nice, thank you. What else? Tone, did you pick up anything new, useful tonight?
Yes.
What?
I like the way that you encourage cooperative learning. I think that's that's my bonus.
A lifetime of training.
I've always been lazy at learning on my own, so if I can get it off of you, I'll be really happy.
Yeah, it's just such a thing. In the real world, that's what happens. But you know, in high school and university exams, you expect to know everything in here. It's a tough gig. Cool. Okay, so we covered that. All right. Oh, now everything that the time there. What you're all looking forward to tonight, the conclusion. I promised what you were going to be able to do is cite the physiological and biomechanical theses of recalcitrant plantar heel pain cases. One more time. Turn to the person next to you. One, pick an A and a B. A is going to talk about the physiological and biomechanical theses, and B is going to talk about the physiological phases. What are those three phases that muscle or soft tissue rehabilitation has to go through, what order and why? Ready? Away you go. Get on out of here. Oh, it's a shocker. Pumpkin sponge, strawberries, please help yourself coffee, tea. There's our coffee maker. Sorry.